What we find now in our chronically ill patients is there's never one thing wrong with them. It's like going to a doctor with 16 nails in the foot, telling the doctor you have foot pain, and tell me how you're feeling. We all know the patient's not going to feel all that well. What I ended up discovering over time with this 16-point model is that all of these factors drive inflammation. And we know inflammation is the number one cause of all chronic disease and in many of the acute diseases also. So where's the inflammation coming from?
Welcome back to the Think Well, Age Well podcast. I am your host, Dr. Heather Sandison. And today's guest is someone who has spent decades asking questions where many others weren't, and helping patients who have felt had run out of answers, where there was nowhere else to turn. I feel very, very fortunate that I have been learning from Dr. Richard Horowitz for years. He is a board-certified internist and internationally recognized expert on Lyme disease and chronic illness. He is the founder and medical director of the Hudson Valley Healing Arts Center. And over the course of his career, more than 13,000 patients from around the world have sought his expertise for complex chronic conditions that have fallen through the cracks of conventional medicine. Many people know Dr. Horowitz as the author of the New York Times bestselling book, Why Can't I Get Better? This is often referred to in my circles as the Lyme Bible. His groundbreaking work led to the development of the MSIDS model, the Multiple Systemic Infectious Disease Syndrome Framework. And this helps clinicians understand why chronic illness is rarely just caused by one thing. And most recently, Dr. Horowitz has published a remarkable paper that we've been talking about in my circles extensively. And it's exploring the reversal of Alzheimer's biomarkers in a patient with chronic Lyme disease using his Dapsone combination therapy, and raising important questions about the role of these infections and in inflammation and immune dysfunction, and of course, cognitive decline as we age. So Dr. Horowitz, I am so delighted and privileged to have you here on the Think Well, Age Well podcast. Thank you for joining us today.
Oh, thank you for having me, Heather. It's good to see you again.
You as well. You have spent decades treating some of the most medically complex patients that exist in the world. Literally, they're flying in from all over to see you. And I'm curious, what originally drew you to Lyme disease when so many physicians, kind of throw up their hands and say, this is too complicated, I'll refer out. What made you dig in?
Well, I wasn't planning on becoming a Lyme doctor. That's one of the jokes in my career is not like I turned to my mother when I was young and went, hey, guess what, Ma? I want to be a Lyme doc when I grow older. I just ended up, moving when I finished my internal medicine residency at Mount Sinai in New York City. I ended up moving up to the Hudson Valley, New York, which back in 1987, and I didn't know it at the time, was the largest Lyme endemic area in the United States. So it was simply, I'm a board certified internist. I'm here to help people. I like to think of myself now as more of a medical detective trying to figure out why people are sick. It's actually what drew me to internal medicine. But when people were coming in with rashes back in the 1980s and early 90s, we didn't really know much about Lyme at that point. So I started on a journey to figure out why a lot of these patients who, kept relapsing off antibiotics, why they got sick. And that led to a 40-plus year journey, seeing over 13,000 chronically ill patients from all over the world. And I credit, my sticking with this, truthfully, with my spiritual teachers who I met in med school. I was studying with the Tibetan Buddhist lamas when I was at the University of Brussels. And one of my teachers told me, Lama Gendon, right before I was leaving, I said, what do you want me to know before I go out into the world as a doctor? And he said, Richard, the most important thing is exchange yourself with others and do for them what you would want done for yourself. He said, if you do this, everything will go well. It turns out, of course, that every time these patients were coming in, they didn't have answers. I kept looking for answers. And, at one point I discovered Babesia, this parasite that was keeping people ill. A woman in a wheelchair for 5 years who couldn't walk, all of a sudden got up and walked, after a few months of therapy. Another woman who couldn't talk. She was aphasic. She had no words coming out of her mouth. Went to Mass General, went to all these. Nobody knew it was wrong. They said it was migraines. Turned out it was Bartonella, another, intracellular bacterial infection. So the MSIDS model that you described, it kind of grew from the ground up as I was just searching for answers as to why these people became ill. And now it turned out I've discovered that the 16-point model applies to Alzheimer's, it applies to autism, to ADHD, in fact, to most chronic diseases on the planet. And that's the basically objective of my new book, Ending Chronic Illness, is to point out that there's other ways of preventing, diagnosing, and treating chronic illness, not just naming the disease and throwing a drug at it.
Right, right. So I want to hear about that framework, but you are known as a Lyme doc. And so I want to dig into this a little bit more. There's chronic Lyme and there's what you described, that rash that, and I'd love for you to even tell us what it stands for. So there's the tick bite and a rash that comes with it, and that's that acute phase. And that's recognized in conventional circles, but this chronic phase is less recognized and harder to test for, certainly harder to treat. Can you just kind of give us the synopsis of that for a minute?
Sure. So right now we're having a tick explosion in the United States. If you go online, you'll see that ER visits are up at least 25% for tick bites this year. It's a massive amount of ticks that are out there, likely from climate change, from the warming of the environment. So it stands for erythema migrans. So you're right. I mean, the early Lyme rash, which half the time looks like a classic bullseye and half the time looks more like a spreading red rash, like a bacterial infection, like a cellulitis. Some people have been mistaken for like herpes zoster, getting shingles or getting a spider bite. Half the time it does not look like a classic bullseye, but what happens is about 75% of the cases, 80%, are going to get better with doxycycline or amoxicillin. But about 25% and more, if you look at the literature, it even goes up to 48%, will go on to develop a chronic form of Lyme disease, which I still refer to as chronic Lyme disease, but it's otherwise known as post-treatment Lyme disease syndrome. And so what this is basically is Borrelia burgdorferi, the agent of Lyme disease, is the great imitator. So these people come in with drenching night sweats and day sweats if they have Babesia, this malaria-like parasite that gets in quite often. They have a chronic fatiguing musculoskeletal illness with migratory joint pain, migratory muscle pain, migratory nerve pain, tingling, numbness, burning, stabbing sensations. And they can have chest pain, shortness of breath, oftentimes memory concentration problems with word finding problems, difficulty falling asleep, waking up in the middle of the night, neuropsych symptoms. Suddenly they're depressed, they're anxious. They even develop things like OCD, bipolar disorder, schizophrenia. So Lyme is really the great imitator. And the problem is the CDC said there was at least 476,000 cases just a year or two ago. Medicare rates are 7 times higher. So we're probably dealing with a couple of million people per year. And many of these people go on to chronic Lyme. And now we know that, according to what I've seen, a lot of these people who've developed what they call chronic fatigue syndrome, myalgic encephalomyelitis, fibromyalgia, even some of the long COVID patients, it turned out it wasn't just like pieces of the virus, the spike proteins or active virus that was making them ill. It was Lyme, it was Bartonella, it was mold toxicity. All 16 MSIDS factors that we'll discuss in Lyme today applied to long COVID. I published it a couple of years ago in the journal Microorganisms. So it's a chronic fatiguing musculoskeletal neuropsychiatric illness, very prevalent, great imitator. And as you said, the testing can be negative in a lot of these patients because they become immune suppressed. Lyme and Bartonella can suppress the immune system where you don't make antibodies. If you've taken antibiotics early on in the course, it'll abrogate your immune system to not make antibodies. And then you get long COVID, your T cells get exhausted, and then you get mold toxins like gliotoxins that suppress your immune system. And lo and behold, you get all these chronically ill patients coming in that are looking for answers.
You mentioned the rash, this erythema migrans rash, and how it can look different. It's not always the classic bullseye rash, but also my understanding is some people will never get a rash, or if they get a tick bite on their scalp, they might not see the rash.
That's
It
true.
might be hidden. Also, my understanding is that it's not just ticks, right? There are other vectors, the other insects, right? Spiders or fleas. Certainly with Bartonella, fleas come up a lot. But I think sometimes people pigeonhole it into, I've never had a tick bite, so I couldn't have Lyme. But there's other ways that we can be exposed. Can you go into a little bit of that?
Yeah, so mostly for Lyme disease, it's usually by a tick bite, but maternal fetal transmission from the mother to the child can happen. Blood transfusions will not happen from Borrelia burgdorferi, but just about every other tick-borne disorder I could mention today, whether it's ehrlichiosis or different tick-borne viral infections, babesiosis, Bartonella, they can be transmitted not only from mother to child, but also by blood transfusion. I mean, even Babesia can be transmitted by solid organ transplantation. But Lyme is mostly going to be seen from tick bites or maternal fetal transmission. And that's tough because we have seen parents who have transmitted congenitally Lyme to their children. Oftentimes they're misdiagnosed. They're told they have autism spectrum disorder, but it's actually congenital Lyme. BART, on the other hand, which you mentioned, BART has a huge number of vectors, and Bartonella actually looks like Lyme. It similarly causes fatigue and headaches and joint pain, muscle pain, neuropathy, memory concentration problems. So it looks like Lyme, but the vectors can be ticks. There's a European species, Bartonella bertolisi, transmitted by Ixodes ricinus ticks. It's still debated how much ticks are transmitting it here in the U.S., but fleas, cat scratches, cat bites, mosquitoes, spiders, keds, which are biting flies, even the triatome bugs, which are some of the newer vectors on the planet right now, which are transmitting Chagas disease, they can transmit Bartonella. Bartonella is a big problem. It's oftentimes misdiagnosed, but it's a big problem, especially in the children that develop new onsets of seizure disorders or neurocognitive issues. So most of those vectors are mostly for BART, not so much for Lyme disease.
Got it. Okay. And I want to go into this MSIDS model. So I want you to explain first what it is, and then why do you feel like it's such a big paradigm shift compared to, say, what you learned in medical school?
Yeah. So we learned in medical school, and you may have learned the same thing, but it was kind of the one cause, one disease model from Koch's postulate or Pasteur's postulate that we learned. And of course, this goes back to the late 1800s when there was a bacterial infection like, strep causing glomerulonephritis or rheumatic fever. But what we find now in our chronically ill patients is there's never one thing wrong with them. It's like going to a doctor with 16 nails in the foot, telling the doctor you have foot pain. And if the doctor doesn't find all the nails or finds one or two nails and says, hey, come back in a month and tell me how you're feeling, we all know the patient's not going to feel all that well. So what I ended up discovering over time with this 16-point model is that all of these factors drive inflammation. And we know inflammation is the number one cause of all chronic disease and in many of the acute diseases also. So where's the inflammation coming from? So the first main 6 factors on the MSIDS model, which I call rivers of inflammation going into an ocean of inflammation, is number 1, infections, which includes A, bacterial infections like Lyme disease, Bartonella, B, parasitic infections like babesiosis, C, viral infections, like you can have long COVID and reactivate Epstein-Barr virus or herpes virus 6, or D, fungal infections. You may have a candida overgrowth in your gut or actually get fungus in your body. And as you know, they've even found it in the brains of Alzheimer's patients. So number 1 is infections. And when you mix these infections with environmental toxins, like mold toxins and heavy metals, I mean, there are ultimately hundreds and thousands of environmental toxins getting into everyone's bodies. But the ones I usually focus on that do a lot of the damage, and we can detox a lot of the other chemicals in detoxing mold, is mostly mold and heavy metals. When you can mix infections and toxins like this, you get a massive amount of inflammation in the body. And then you combine it with microbiome abnormalities in the gut. You've got the wrong type of bacteria. You don't have enough short-chain fatty acid bacteria to lower inflammation. The 4th point is leaky gut with mast cell activation, where you get things like lipopolysaccharide that gets across the intestinal barrier, causes a blood-brain barrier to get leaky. You get then inflammation in the brain. So points 3 and 4 is microbiome, leaky gut, mast cell. And then the 5th and the 6th are vitamin mineral deficiencies, because your body has to detox all these chemicals and deal with the inflammation from infections. And number 6, insomnia, where people just don't fall asleep or keep waking up in the middle of the night. And that happens from Lyme, but even young, thin women have come in with sleep apnea. Men can have benign prostatic hypertrophy, women in menopause. There's a lot of reasons why people don't sleep. But the point being, when you combine these infections with toxins, with microbiome issues, with leaky gut and mast cell activation, with vitamin mineral deficiencies and sleep disorders, I mean, even in sleep, you know this with Alzheimer's, the glymphatics, you need those glymphatics to take the garbage out at night. Otherwise, you get these pathological proteins of, p-tau and amyloid beta that accumulate. Those are the 6 major factors on the MSIDS model, and they have downstream effects from the inflammation. So, for example, the mitochondria in your body have nothing protecting them from all this free radical oxidative stress. In Alzheimer's, right, and what you've been looking at, we know mitochondrial dysfunction was one of the hypotheses, but where's it coming from, right? So infections and toxins can drive it, but we also see hormonal dysregulation. People come in with low adrenal function, low testosterone, women go into early menopause. We get immune deficiency or autoimmune reactions because as your immune system is trying to fight Lyme, Borrelia, you get a lot of autoimmunity in the body with anti-nuclear antibodies and rheumatoid factors and anti-gangliosides. So you combine this with deconditioning and liver issues and neuropsychological issues. It's basically a lot of inflammation in people. And Lyme, as I said, it's the great imitator because most of the patients who've come to see me over my 41-year clinical career, they were not all diagnosed with chronic Lyme. They came in with a diagnosis of long COVID or chronic fatigue syndrome, myalgic encephalomyelitis, fibromyalgia. Some of the cases of dementia that have come in fact, weren't what I would call true Alzheimer's dementia. It was Lyme-induced neuroinflammation driving those biomarkers, which we'll talk about. So in this day and age, when someone comes in with an illness, I don't find anymore that it's one thing making them sick. That model we learned in medical school is pretty much outdated. So, that's what we're finding is really needed to get these chronically ill patients better.
When you have people frustrated with the conventional system and, it takes them a long time to get in, it's like a pill for every ill, but that's what's covered by insurance. How do you help patients navigate sort of this frustration of, but that functional medicine, MSIDS type framework is outside of what I can afford? And I don't mean to put that all on you, but it's something I struggle with, right? We want to help as many people as possible with dementia, but it's not covered by insurance. And so how do you help people square that? Is there an empowering message that we can leave, that people can take away today around this?
Sure. So, fortunately for me, almost every protocol I have published in the medical literature over the years are generic oral drugs that are covered by insurance. So
Amazing.
oh yeah. Oh no. And in fact, if someone comes in, I'm probably drawing like 35 vials of blood on the first visit. But fortunately, Quest, LabCorp, BioReference, the local labs cover it. People usually do not end up with bills because of the coding, right? If you're coding correctly, most of the time, the coding covers it. They don't end up with big lab bills. And Dapsone combination therapy, which I pioneered for the treatment of chronic Lyme, it's all oral generic drugs. You go to your CVS pharmacy or whatever, it's covered by insurance. What's not covered is the probiotics for the protocols or some of the folic acid supplements I'm using or using glutathione to help protect you from Herxheimer reactions. But honestly, when you consider that most of these people have been to 10, 20, 30, 40 doctors before seeing me, I have developed these protocols in a way that they're short, they're fast. I get people better and they're out of the office so that, we can get new people in, but it is mostly covered. But you're correct. Like for example, a mold test from real-time laboratories can be a few $100s. It won't be covered. But what I find is if we give the code for mold, once the test comes back positive and they apply for their insurance, a lot of times they will get money back, but you don't always get it up front. But fortunately, the way I've developed these protocols, most of the things are actually covered. So, but you're correct in the functional medicine space. Of course, there can be a lot of tests that aren't. The heavy metal tests we've used, most are, in the serum, which won't always cover it. But even the 6-hour urine DMSA challenge from Doctors Data was $60-$70, at the time. It was not a highly expensive test. I'd say probably the biggest issue is if you're not a Medicare patient,
Right.
getting some of the Lyme testing, we can get it through the local labs again, ELISA, Western blots. All of the regular tick-borne infections are covered again through local labs. Ehrlichia, Anaplasma, Babesia, Bartonella, Rocky Mountain spotted fever, Q fever, tularemia, they're covered. But the problem is there's so many strains of Lyme disease, we usually have to use specialized labs like IGeneX. Again, they will discount them, but, you'll probably pay about $300 to get, an IgM and an IgG immunoblot. It's not nothing, but it's not thousands and thousands of dollars. So when I have to establish the diagnosis, I have a questionnaire on my website, cangetbetter.com, costs no money to fill it out. And it gives people a pre-test probability of what is the likelihood you're actually going to have Lyme disease. And if you score over 63 on this questionnaire at cangetbetter.com, it tells you, hey, I really should get tested. Now, you can get tested through the local labs, but if it comes back negative, you then really need to do some of the specialty testing because a lot of times we need to do FISH testing, which is fluorescent in situ hybridization. It's an RNA test, very useful for strains of Babesia and Bartonella. But if you just start with an immunoblot from IGeneX, or even look at the bands on a Western blot through a local lab, there's a game I play with patients called Lyme Bingo, which is if you have any one of these numbers on a Western blot or an immunoblot, bingo, you've been exposed to Lyme disease. And those numbers, people can take notes on this, is the 23 band. 23 is the outer surface protein C, the 31, the outer surface protein A, the 34, the outer surface protein B, the 39, very specific band for Lyme, and the 83/93. Now, a local Western blot, if there's a 31, could theoretically be due to Epstein-Barr and autoimmunity, but in real life, it's Lyme like 99% of the time.
And
So
41 is super common. It comes up on absolutely everyone, but non-specific, right?
yeah, yeah.
Yeah.
So there's ways of getting through these tests without spending a fortune. Honestly, I find that most of the monies that people have spent is usually before they've ever come in to see me
You
because
know,
they've been to so many doctors getting tests trying to figure out what's wrong with them
what's
and never got
wrong?
to the source.
Yeah, and then not being able to work, right? Being a burden on their family potentially. The caregivers can't work. It gets very expensive, not just directly paying for medical costs, but it's like it's all the opportunity costs. I just want to take a minute to applaud you and thank you for being aware of that piece of this and for making this as accessible as possible for people because in these circles it is challenging and people deserve good medicine. And so thank you for finding the ways to make the labs accessible and to make the treatments accessible and creating that as part of your protocols. I really think that increases the impact and it's not easy, right? It's easier to just spend more money.
Well,
So
I,
thank
I
you.
recognized early on that we were in the middle of an epidemic of
Yeah.
tick-borne disorders. And now, of course, what's really interesting is now we're putting together the epidemic of Alzheimer's disease and the epidemic of Lyme disease. There is maybe a reason why there's a bridge between these two. As you know, they've talked about in the medical literature in autopsy studies for years that they would find Borrelia burgdorferi Lyme in the brains of Alzheimer's patients with biofilm, with amyloid beta, with phosphorylated tau. But it was always someone who had died in an autopsy study that had never been in a live human being. So I recognized early on, in a worldwide epidemic, I had to find a protocol that was not IV, that was oral, generic, that any person across the globe could take it. And I published it in open access journals, right? So that anyone could go read my literature. They don't have to come to see me, and get this protocol. And I've done medical detective substacks, which are also free to sign up, where I've explained these protocols and in my new book, Ending Chronic Illness, it'll be out this October. I basically
Congratulations.
have a section on the three Bs, Borrelia, Bartonella, Babesia, where I explain these protocols like a cookbook that anyone can pick up this book and understand how to do these protocols, that if God forbid I should not be around tomorrow, people would be able to take this book and run with it to find answers for Lyme. I mean, my wife was sick for 25 years. She's 8 years in full remission since she did the double dose Dapsone protocol.
That's an incredible personal testimonial and story. That's phenomenal. Congratulations on your book. Thank you for making this an open book. Like literally, it's an open book about how to do this. I'm curious, as we shift the conversation into dementia and Alzheimer's and this clinical case that you published around the biomarker reversal, how often do you think that these infections are only one part of a larger puzzle when it comes to age-related memory loss?
So based on the fact, so in the article that I recently published, this was just a month ago in April in the Journal of Alzheimer's Disease Reports, what I found is that just like I published for Lyme, that there were these 16 MSIDS factors making people ill. And in 2024, I published in the journal Microorganisms, these 16 MSIDS factors were associated with long COVID. Now I published in this journal that all 16 MSIDS factors are associated with Alzheimer's dementia. Now, from my perspective, what do I think are going to be the most important factors? I do think it's multifactorial, and you can tell me your take from having been in the field for so long. But I do think it's probably a combination of bacteria like Lyme combined with viruses, whether it's herpes virus 6, 7, 8, or herpes virus 1, or EBV. I do think it's a combination of bacteria and viruses that are probably, along with these environmental toxins. JAMA Neurology was publishing years ago, they would find pesticides in the brains of people driving amyloid production. Knowing the number of hundreds and thousands of toxins getting into people and knowing how bad these infections are and knowing that these environmental toxins are completely destroying the microbiomes of guts, where we now don't have that short-chain fatty acid bacteria to lower inflammation, I think those first 6 factors on the MSIDS model that I discussed with infections, toxins, microbiome issues, leaky gut, not getting to sleep adequately, and vitamin minerals are probably at the top of the list. But if you happen to be a type 3 diabetic with, people with high insulin spike, of course, that's going to be a major factor if you're one of those people. But even dysautonomia, right, was playing a role in some of these patients. Mitochondrial dysfunction is playing a role. But of course, my take is Is it the infections and toxins that are causing the mitochondrial dysfunction? So, with these anti-amyloid drugs, I applaud them for trying to use them, but it only lowers it. In the Cochrane review that came out 1 week before my article got released, it basically said they're not really changing the clinical course. They're lowering these biomarkers. They're slowing it down maybe, but we don't really have good answers. And this is the first time. By the way, when I submitted the article, I didn't realize this was the first time anyone had ever reversed p-tau217 completely. I was completely ignorant of this when I submitted it. And then I realized this is actually a big deal because the anti-amyloid drugs were lowering it by 23% over 6+ years. I lowered it by 63% in 9 weeks, but it's because in my patient, it was obviously that the p-tau was being driven, in fact, by Borrelia burgdorferi. So I do think it's going to be multifactorial. I don't ever think in Alzheimer's dementia you're going to find one factor, but there might be one that is at the top of the list. Like in my patient, I treated her heavy metals. We treated her for Q fever. I indirectly treated her for BART. She had metabolic syndrome with an elevated hemoglobin A1C. So she had other factors that could have caused memory loss. But we kind of addressed it. Her B12 was borderline, but we addressed all these, right? So ultimately, I think in her case, it was infections. But I think if we were to do, thousands of patients, and this is what I hope will happen, the neurologists out there, if they were to check for all 16 MSIDS factors in their dementia cases, it may turn out that there's 2 or 3 or 4 factors that are the main ones driving it. But my concern with the Lyme epidemic now showing a relationship with the Alzheimer's epidemic, we have to make sure that Borrelia burgdorferi is not there, because then you may actually have a treatable cause. I mean, we won't know until we do a multi-center placebo-controlled randomized trial, the gold standard of medicine. This is one case study. I can't, go too far on what the implications are. But knowing that in the 375 dapsone cases I published over 10 years, the number one statistical effect was always memory, concentration, word finding. It was always 70% of the people said the number one thing that got better from dapsone was memory concentration. And whether that's because it was an NLRP3 inflammasome inhibitor lowering inflammation in the brain, which, by the way, might really be a reason to think about repurposing this drug, even if you don't have Lyme disease. Maybe it's chlamydia pneumonia, right, that's driving it, and maybe these same drugs will help. We won't know until someone really takes the time to look at all 16 factors, use dapsone independently from infections like Lyme as a repurposed drug to lower neuroinflammation, and see what we have. But the beauty of it is at least gives hope. Like, at least we have a new research. I opened the door a little bit to get some light into a field that really needed it.
Yeah. And it was the p-tau217. That was one of the biomarkers that was reversed. It basically went from positive to negative, right? And reduced by, you said, 63%, right? That's phenomenal. Were there other biomarkers that you looked at? Was there an NFL or A-beta ratios? Did you look at other things?
So we did. So her p-tau 181 was normal. Her beta amyloid 42/40 ratio was normal. But what was fascinating about the case, and again, I learned all this while I'm going through the literature, and the p-tau217 came down, her beta 42/40 ratios improved. So when I published the article, what it showed is that the Quest Labs has this really beautiful graphic, and you can see that the graph is going up. And and for the listeners who are listening, you don't want a low beta 42/40 amyloid ratio. It's the 42 protein that's the sticky form that's really causing a lot of problems. You want it actually to go higher, and that's what happened in our patient. It actually showed from Quest Labs that there was less amyloid production showing up as the p-tau217 went down. But she had a normal neurofilament light, normal p-tau 181. Her initial beta amyloid 42/40 ratio was normal, but improved. You could see it was actually getting better after we did the dapsone 9-week therapy.
And what was your reaction when you saw that, when you saw her labs come back?
Well, I was jumping up and down for joy. Literally, I was like a kid in a candy store going, because I didn't know it was going to work. She was one of the few patients at the end of my 41 clinical career who'd never done dapsone. And she'd been putting it off for 15 years. She had not taken any antibiotics for 15 years. So I was really excited because I recognized, like, oh my God, this is such a wonderful result, but I didn't know the full implications until I started writing up the article for review, and then realized that it had never been done, and that the Alzheimer's Trailblazer study that they had done back, 4 years ago in JAMA lowered it by 23% in 6 years, and I'm lowering it by 63% in 9 weeks. It's like, okay, you guys were trying to pull out amyloid, but maybe the reason it wasn't always working was because Borrelia burgdorferi or chlamydia pneumonia or other bacteria were there. Now, honestly, if I was a pharmaceutical company making these, I would want to do a parallel study to see how effective these drugs are once you start hitting Lyme. It could be that if the amyloid in p-tau is due to mold or due to heavy metals or due to these other MSIDS factors, these drugs may actually end up being much more effective than they are right now. So that's a study that definitely needs to be done.
Yeah, couldn't agree more. And I think some people will hear this and assume that we're saying Alzheimer's is caused by Lyme disease. But I think I want to make sure that we zoom out, that you're describing these MSIDS. Dr. Bredesen talks about the Bredesen 7. My framework is the 6 primary level drivers, causes of neurodegenerative disease. And so I think that we want to make sure that we put all of this back into that framework. Lyme disease generally has been, I think, underrepresented, particularly in conventional communities, particularly at this chronic form, this longer form Lyme disease. And what we're saying is that, yeah, that might be one of the primary drivers for some people of dementia, of neurodegenerative disease, because of the role of infection triggering the inflammatory process.
Correct.
So, okay, we're in agreement.
No, absolutely not. I mean, if the literature says, if it's right, that maybe a quarter of the cases, somewhere between 25% or a little higher, of what's now being diagnosed as Alzheimer's, because when I saw this patient with p-tau, by the way, I had many patients before I finished clinical practice. Probably half of them were showing up with these Alzheimer's biomarkers. So the problem is, I thought at the time, it's Borrelia and it's other things driving, these pathological proteins driving neuroinflammation. But then I realized if my patient had gone to a board-certified neurologist with a high p-tau 217, she would have been diagnosed with Alzheimer's, not Alzheimer's due to Lyme disease, because the American Academy of Neurology doesn't even look for Borrelia burgdorferi as a cause because it's all been autopsy studies. It's never been proven in a live human being. So yes, I mean, clearly your framework and Dale's framework and even mine, they're all, as you know, they're all kind of synchronous. We're all talking about the same thing. It's only going to be a certain percentage of these cases, but it now means if you've been diagnosed with this, it's at least something you need to look at, because there might be a potential solution. Again, until we do a really good randomized multi-center placebo trial, we're just not going to know.
Right. And I think if hopefully all of our listeners here have heard this before, but amyloid and p-tau are antimicrobial, right? They are there to protect us. And so, and inflammation is also there to protect us. Now, inflammation can get stuck on, just like amyloid can get stuck in the on position. p-tau can get stuck in the on position. And so we want to be able to turn those off. But the way to turn them off is not to just take them out, not to just reduce inflammation, not to just extract the p-tau or just extract the amyloid, but to ask the question of why. Why is the brain needing to protect itself? Why is there an inflammatory cascade being turned on in the first place? And so you've found associations between all of these 16 MSIDS factors and Alzheimer's disease. I think we've gone through 6 of them. I want to make sure we go through the other 10. And then I'm curious, which are the most important ones in your mind, particularly when it comes to aging and age-related memory loss?
Mm-hmm. So the 10, so after the 6 rivers of inflammation, which again is infections, environmental toxins, microbiome issues with the wrong type of bacteria driving inflammation, leaky gut with mast cell activation, vitamin mineral deficiency, sleep. Those are the main 6. The 10 downstream effects are mitochondrial dysfunction, which mitochondrial hypothesis and the amyloid hypothesis and autoimmune. There's all these hypotheses with Alzheimer's, but from my perspective, it's like, well, these infections and toxins and sleep disorders drive mitochondrial dysfunction. So that's number 7. Number 8 is dysautonomia. People will get definitely POTS dysautonomia. We see immune dysregulation with immune dysfunction, where some people have chronic variable immune deficiency, but we also see a lot of autoimmunity. So immune and autoimmunity are some of these factors. We see neuropsychological issues, so neurological symptoms, psychological symptoms, the liver. It turns out with these people who have non-alcoholic steatohepatitis, NASH, or fatty liver, 1/3, which is 1/3 of the world's population, they have metabolic syndrome and insulin resistance. And we know that these blood sugar spikes with insulin will affect the brain, right? It's one of the known causes of how you can get inflammation in the brain. And then there's people who become deconditioned over time from their illness. Those are really the main factors, in the 10 downstream effects of how this affects people. And in my view, the biggest ones ultimately are going to be infections and toxins, microbiome, sleep, as we talked about earlier. But that doesn't mean in an individual patient, like hormonal dysregulation, you get inflammation in the brain, it affects the hypothalamic pituitary axis, and the hormones get dysregulated. And we know with low estrogen, you go into menopause, there's memory loss. All of this may play a role. And in some people, it may be that the hormones are playing, a big role, as is dysautonomia, as is immune dysfunction, autoimmunity. I don't think you'll ever probably find two people that will be exactly the same. But for me, the broad brushstrokes is that it's probably going to be, because in my world with chronic Lyme, when I treat the infections and toxins, that's usually is the biggest factors that get these people ill with chronic Lyme. And as I said, 70% of these people who've taken dapsone combination therapy for chronic Lyme say memory, concentration, cognition is my number one best effect of doing this drug regimen, and it's durable. And that's why I think it probably is going to work in the Alzheimer's space, is because I don't see people relapse from their cognitive issues when they've done dapsone if the other MSIDS factors have, been adequately treated. Yeah.
I hear the same thing from patients who have done the hyperthermia treatments. What are your thoughts about hyperthermia treatments for Lyme, for treating Borrelia?
It's an interesting hypothesis because they found early on that if you heated up the body temperature at least 104 degrees for 2 hours or more, you could kill spirochetes. So I think there's definitely a group of people who go to Germany who do hyperthermia who will get some help. But here's my biggest problem. Lyme and Bartonella are what are called biofilm persister bacteria. So they go into hiding under these biofilms where your immune system can't recognize them and your antibiotics don't penetrate easily. And these persister forms are a type of the bacteria that go into dormancy. So that's why when you stop ibuprofen, I've had patients take IV drugs for Lyme for a year, not with me, but with other doctors, come to see me. And within 1 month off the ibuprofen, the symptoms are back. It's like, well, why didn't ibuprofen kill the bacteria? Because ibuprofen does not hit these biofilm persister forms. The way I designed the protocol is looking at the tuberculosis leprosy drugs, because TB and leprosy are biofilm persister bacteria. That's how I came up with the idea of doing this, because they use rifampin and dapsone to cure leprosy. So it wasn't all that brilliant. All it was is, hey, I wonder what happens if I add a tetracycline to rifampin and dapsone, because tetracyclines hit Ehrlichia, Anaplasma, Rickettsia, and it turned out it was a home run, out of the park with this. So I do think that hyperthermia has its place, but ultimately I've seen too many people relapse. So I think what it does is it probably lowers the load, because you will knock off a certain amount of the bacteria, but ultimately I don't know that there's any proof that hyperthermia is affecting the biofilm persister forms, just like a lot of these alternative therapies like SOT therapy. Some people, SOT therapy will shut down these bacteria for a while, but I've heard it comes back later on, right? Because you're just putting kind of like a lock in the key to shut off the bacteria for a while. But if you understand, like TB, you need to use 4-drug regimens specifically for this type of bacteria. Once you understand that Lyme and BART are a similar type of bacteria, so I think these other therapies have a place. But from my perspective, not only are they highly expensive, you were talking about, what it costs to do some of these integrative therapies. SOT therapy could be $3,000 a pop. You go to Germany, it's $15,000. Dapsone therapy is nothing like that. It's a generic all-drug regimen. Don't get me wrong, you might pay $1,000 for supplements and folic acid, but it's nothing like what you're going to pay for some of these therapies, and you've actually got a durable answer. So I do think there is a role for these things, but I just don't think it's getting to the source of where these bacteria are hiding in the body.
Got it. For listeners who have either a diagnosis of mild cognitive impairment, or maybe they're ApoE4 positive, they've got high risk, family history, maybe even somebody with Alzheimer's disease and dementia, what practical lessons do you want them to take away from the paper you recently published, and also from your work and its implications for Alzheimer's?
So the main points for me is when I did this deep dive into the medical literature, again, discovering the 16-point model applies to chronic Lyme, it applies to long COVID, it applies to Alzheimer's. When I did a 1-year deep dive into this book, what I discovered is the same 16 MSIDS factors was applying to ADHD, autism, Alzheimer's, allergies and asthma, the 3 Bs, C, cancer, cardiovascular disease, chronic fatigue syndrome, myalgic fibromyalgia, hormonal dysregulation, immune disorders, autoimmune disorders, including rheumatoid arthritis, where the 16 factors were showing up in these patients. Same for MS, multiple sclerosis. All 16 factors shows up, as well as mood disorders, depression, anxiety, OCD, psychosis, bipolar disorder, and these viruses. So it's kind of like, hold on, we're in the middle of a chronic disease epidemic where 60% of Americans have at least one chronic illness, 25% of Americans have two or more chronic illnesses. Just this morning, a paper just